Diabetes insipidus. So remember, we have diabetes mellitus, type 1, type 2, and then we have diabetes insipidus. Diabetes insipidus is associated with the pituitary gland. Remember, this is a bilobular structure, sits under the thalamus, or the hypothalamus rather, and it has two lobes, and you've got the anterior lobe and the posterior lobe. The posterior lobe it is from which ADH and oxytocin are released, hence ADH. ADH, antidiuretic hormone. Remember, if something is a diuretic, for example tea and coffee, it'll make you go to the loo more often, so you'll be urinating more often. And that's what, now if it's an antidiuretic, what's going to happen is it's going to actually work on the nephrons, which is where the urine is made, as you'll appreciate. In the kidneys, the functional subunit of the kidney is the nephron, about 1 million in each, in both kidneys. Now the nephron, the ADH, antidiuretic, meaning that it's actually going to negate the effect of diuresis, i.e. stop you from going to the loo, i.e. retain water. And that's what antidiuretic hormone does. ADH, also known as vasopressin, is a hormone that helps you to retain water. Okay, release again from the posterior pituitary and acts primarily on the distal convoluted tubule and the collecting duct. Of the 1 million nephrons, of the approximately 1 million nephrons in each kidney, you've got about 15% which are juxtaglomerular, and then you've got the other ones, of course, the 85%. Now, the cortical. Now, diabetes insipidus is an issue where the posterior pituitary is not releasing sufficient amounts of ADH. Or is it? Okay, so the question here is the diabetes insipidus a fault in the posterior pituitary lobe, or is there a defect in and around the nephrons, hence nephrogenic? So what we've got to do in the context of diabetes insipidus, the symptoms for which are very similar to diabetes mellitus, i.e. polyuria and polydipsia. You'll drink like a camel, yet you'll still feel thirsty, or rather the patient will, and you'll pee large volumes, and this is one of the key statements that patients make. They are urinating large volumes of clear, relatively clear water, so the urine that comes out is odorless and relatively colourless, and it's large volumes. These are key indicators, and yet they're drinking sheer volumes of water on top of that. So deductions to be made here when we do investigations, therefore, is that the urine osmolality. Now, osmolality essentially means concentration. That's easier to remember it. So urine osmolality in diabetes insipidus is low. Okay, and serum osmolality in these situations is high. Why? Because you're getting rid of the water, and so the concentration of your fluids in your body are therefore going to be high, hence high osmolality. Now, what do we then do? We then, in order to differentiate between nephrogenic and cranial diabetes insipidus, we do an 8-hour water deprivation test. So we prevent the patient from drinking any fluids for 8 hours. We then take a sample of the urine and we measure the urine osmolality. Okay, not that I've done this, but from colleagues and acquaintances, if I were to taste this, it would taste like water. I'll let you try it and let me know. The key, after 8 hours of water deprivation, the urine osmolality is low. What you do then is you give the patient desmopressin. Desmopressin is a synthetic version of vasopressin or ADH. And so think this through now. If I've just given you ADH, synthetic version, now if my urine osmolality therefore increases, that means that I've actually retained some water in the body, and therefore the urine being produced is going to be a relatively smaller amount and less dilute, hence the urine osmolality is going to be higher. It's going to be more concentrated. If that happens, so then after the desmopressin, you check the osmolality again. So essentially what you're going to do is 8-hour deprivation, check the urine osmolality, then give them ADH, and about an hour or so later, you're going to measure the urine osmolality again. You take a second sample. If the urine osmolality increases, again, as I said, it becomes more concentrated. Why? Because the water that has been, the antidiuretic has actually worked, and it's actually retained some of the water in the body. So the volume has decreased somewhat, but more importantly, the urine osmolality has increased. That means that the defect is actually in the amount of ADH being produced, or a defect in the cranium, or hence cranial diabetes insipidus. If, however, after the desmopressin, the urine osmolality remains low, the change is not significant, if any, that means that the fault is not in the ADH being produced by the posterior lobe, be it defective or amounts or anything like that. Rather, the defect is in the nephron. Remember, we said ADH works on the distal convoluted tubule and the collecting duct, 10% on the collecting duct, the remaining on the DCT, to actually retain the water. It's aquaporin 2 the aquaporins, type 2 aquaporins, which actually embed themselves in the collecting duct, the wall of the collecting duct, and therefore retain water. If the ADH is still there in the amount, because you just provided it, but we're still not seeing a difference in urine osmolality, that means the fault must be on the nephrons. Hence, we then conclude for this to be nephrogenic diabetes insipidus. I hope that helps. As a summary, 8-hour deprivation, water deprivation test. So you deprive them of water for 8 hours. You check the urine osmolality. You give them ADH. Wait for an hour. You check the urine again. If the urine osmolality increases, that means that the defect is appear. So it's cranial diabetes insipidus. The next thing is to work out whether the ADH being produced, otherwise it's defective, or is insufficient in the amounts being produced, or is the hypothalamus at fault, or is the pituitary at low. So essentially work out that. If the urine osmolality remains low after the desmopressin, then we conclude that the fault is on the nephron, and further investigations will therefore be conducted to determine the exact cause in that situation. I hope that helps. Thank you for watching.